India Institute of Medical Sciences and work in RP Center for last more than 35 years now. I'll begin with the same question which Dr. Abhay started with. Why multifocal IOLs are acceptance is so less in our country? Why it is difficult? I think some of the questions he answered very well in his talk. I think most important thing which we are seeing is it takes much more chair time before surgery and after surgery. You need to be with the patient, explain all the details, pros and cons of multifocal IOLs. And most importantly, I think the ideal patient selection is critical for success of multifocal IOLs. That indicates that not 100% of patients will be suitable for a multifocal IOLs. So you need to have ideal selection that will be based on anatomical features as well as the requirement of a person and the expectations from either side, maybe surgeon or a patient. Then he also talked about does require a more sophisticated equipment, which may be IOL master or optical biometers or topography systems or some sort of aberrometers in pre or post-op examination. That would increase the cost of investment in these type of cataract surgery scenarios. Then other important thing, which I think is still with the major general ophthalmologists, is these multifocal lenses would have more photic symptoms, which may cause a serious issues in a post-op period with the patient and surgeon. And there have been a past lot of literature suggesting many people have explanted the multifocal IOLs. And apart from that, the poor contrast or poor visual quality is another factor maybe there in these multifocal IOLs. And maybe the IOLs per se is a more expensive proposition than a normal monofocal IOLs. So this part has to be seen by our manufacturers so that the price comes down. And effectively in the Indian scenario, reimbursement of cataract surgery is low, which may not cover the multifocal IOLs. So that also has to be looked into. But I think the major concern in Indian scenario, as we know, the largest number of surgery are done at charitable or government setup, where the people don't have enough time. The patient load is so much, they can't give so much of time to explaining the patient. They are paid for, not for a surgery, they are paid for the jobs. But in private sector, this may be different. So all these issues are there, which we have to discuss subsequently in this webinar for our cases. We all desire multifocality, right? From the life of birth of a person to an end, we want to have a multifocality in terms of personality-wise or a seeing vision quality-wise. In that way, after cataract surgery or a presbyopic surgery, multifocal IOLs has been a great advancement in the future. So this is what we like to see after cataract surgery. I tell my patient, if I do cataract surgery, your vision will be as good as 20-year-old person. But the clarity should also have the binocularity, the stereo acuity of persons should be as good as younger person. So that would need to be assessed in these patients. As Dr. Abhay talked about, the actual evolution of multifocal IOL started with the actual bifocal design, which had an upper half for a distance and lower half for near like a bifocal spectacles. Then we gave the refractive types of multifocal IOLs, which had concentric annual zones of varying focal lengths, and they were pupil dependent and a lot of problems with the photic symptoms in these lenses. Then came the diffractive design, which were better in terms of decreasing glare halos, and they were a more acceptable proposition for our patients. But they would never give a 100% independence with glasses because of intermediate vision was problem with these multifocal IOLs. Then now we talk about newer generation multifocal lenses. They are basically trifocal lenses or an extended range of vision IOLs, which might give optimal visual quality, which we desire for our patients and improve the quality of vision and life for these patients. This is how multifocal lenses should look into. If I say today, bifocal is out of practice, for most of us, trifocals are there. Extended range of vision is also coming in picture, almost there for to be taken up as good as trifocal lenses. And unfortunately, physiological concept accommodation with IOLs still needs to be worked out for future. So these trifocal that Dr. Abhay nicely talked about, they'll have a three focal points for distance, near and intermediate areas. They would improve the quality of vision. Maybe they also increase the light transmission so that your contrast become better. This is one of the first trifocal which came in the market from Physiol Fine Vision. And subsequently, we had a J S coming with the Ateliza Tri, which also had asymmetric light transmittance technique where pupil size independency was there, which is good, and decreased photic phenomena in these cases. So they had a near 40 and distant 80 centimeter, which Abhay showed very nicely, and light distribution in this pattern. While Panoptics would give you a better 60 centimeter intermediate and 40 near, a little bit of continuous vision. This part Abhay has nicely talked about. I'll just skip this slide. And just to give you some sort of a composite comparative assessment of their physical character and the quality of lenses, I would first go the material of these lenses. If you look into Ateliza Jai, it's a truly hydrophilic acrylic with hydrophobic surface properties. And Physiol has now also have hydrophobic acrylic also. Initially, it was hydrophilic acrylic with 25-26% water content, while Panoptics is a purely hydrophobic acrylate with methacrylate copolymer in that. So looking into a material-wise, most of lenses are hydrophobic, which is a good design for a long-term posterior capsule compatibility-wise. Technology, this is trifocal diffractive Ateliza and non-apodized with central 4.3 millimeter is the area and periphery is the bifocal design. While Physiol would have a trifocal diffractive apodized system with diffractive whole optic design. Panoptics, you know, it has a hybrid technique, diffractive, refractive area, and the peripheral is totally refractive design. It is a modified quadrifocal, as Dr. Abhay nicely described, where you have an equal distribution of a fourth peak or a fourth focus to distance and intermediate. While the important issue is the light transmission for these multifocal IOLs, which is going to give you a better contrast and better vision for your patient for all distances. If you look into Ateliza, it has 85.7% light transmission, 50 distance, 20 intermediate, and 30 near. While Physiol has 86%, the Panoptics from Alcon has 88%, where 50% were distance, 25% near intermediate. So that is a distribution these have. As far as intermediate vision is concerned, 80 for Ateliza and Physiol, while Panoptics at 60 centimeter with continuous range of vision from 40 to 80 centimeter, which is the advantage of this particular design IOL. Near and is almost similar all, except for if you look at intermediate, the Panoptics has a plus 2.17. So this gives a better intermediate vision for our patients. And central diffractive zone is 4.5 millimeter for our Panoptics, while other designs have a larger central zone in these cases. Pupil independence is important. I think Panoptics also independent to pupil as such. So once you look into that, what are the other options we have apart from trifocals? As I talked about, we do have a extended range of vision IOLs where we don't have a distinct focal point for each distances. They should give, in terms of practically of physics-wise, better quality of vision access. So these are newer generation extended range of vision which may be available or which are there in our country also. Fine Vision have come out with a new technique which is called Triumph, which has an elongated depth of focus energy with 1.75 for a intermediate at 3.5 for a distant near. This is their SIFI Mini Well IOL, which is continuous ERB lens. Technic Symphony was there with us for last 5 or 6 years. We have very good experience with that lens. And now they are coming with a Technic Synergy, which might give you a wider range of vision in terms of improving near and intermediate also. The clinical outcomes in terms of visual acuity wise, there's a lot of literature on these multifocal and trifocals as well as ERB lenses in terms of distance, uncorrected distance visual acuity, corrected distance visual acuity, near visual acuity, intermediate visual acuity, but they are all different categories of cases. I've just summarized in one slide the entire results outcome of these trifocal ERB IOLs. If you look into distance visual acuity, most lenses give very nice distance acuity from these trifocal lenses, the ERB lenses. While intermediate vision, where if you see here, if you look into 80 centimeter, Symphony and Ateliza are better than Panoptics. But if you look at 60 centimeter, which is much more adaptable distance, Panoptics does better than other lenses. While near vision panoptics also scores on Atleasa and Symphony, I think because of the technology we have in these cases. What about other visual functions in these cases, these studies, with trifocal IOLs? MTF, again, if you look into distance and intermediate focus, panoptics is the highest, better MTF in these cases. For near, Atleasa scores over other lenses. MTF peaks, if you look into a panoptics, is at 40 and 60 centimeter, Atleasa 30 and 80. So that's a difference we are seeing, and it has to be titrate with the patient's requirement. I think, and again saying patient requirement is the foremost in these selecting these lenses. Halos, all of them seem to have less halos than previous generation multifocal IOLs. This is a study by Daniel et al. On optical bench performance of 3 trifocal lenses. They found the image quality, resolution, and photic phenomena were comparable with all the 3 lenses, but panoptics had a better intermediate vision at 60 centimeter. So real-life tasks such as computer work was better with the panoptic lenses. This, Abhay talked about, panoptics has a wider continuous range of good defocus curve from 40 to 80 centimeters. And the visual quality also, if you see this simulated headlight image from various lenses, panoptics gives the best image in these cases as good as monofocal lenses. So this is one study I got it, which is a meta-analysis of 9 studies with more than 1,000 eyes, where they looked into all multifocals, trifocal, and ERB lenses. They found that near vision was worse with ERB IOLs. They were better with the trifocal lenses. Significantly better defocus curve in terms of trifocal lenses. While if you compare ERB or trifocal lenses, halos, spectacles, they were comparable in this regard. So this was the summary of literature which I could get on a trifocal and multifocal lenses. It is apparent that if you have a better intermediate at 60 centimeter, gives a better acceptance from a patient point of view. We also have done studies on both ERB lenses and trifocal lenses. So this was our publication on stereo acuity. I understand whenever we do surgeries or a patient has 2 eyes or both eyes has to be tested in terms of what is the binocular function after implantation. So that can be judged by stereo acuity testing for distance and near. Most studies have focused on a distance stereo acuity. This was one of the first studies where we looked into a near stereo acuity after bilateral implantation of Symphony ERB lenses. And we found that it gives an excellent stereo acuity for distance. It was as good as the monofocal lenses. For near also, the stereo acuity was very good with the ERB lenses. And patient didn't have a significant glare halos and night vision problem with ERB lenses. So that gave a clue that we need to study, because panoptics have come to us for last now more than a year with us, 2 years now. Then we thought of doing a prospective study comparing panoptics with ERB lens in terms of primary outcome in terms of near and distant stereo acuity to test the actual binocular function of patient after implantation in these cases. And this particular work is going to be presented this year in American Academy virtual program. So we had 20 eyes in a prospective study where we looked at visual quality and near distance stereo acuity. Let me take you through what was the outcome on a visual acuity wise, comparing these 2 cases. So if you look into uncorrected binocular distance acuity at 6 months, distance near intermediate. So this is ERB lenses, this is trifocal lenses, and this is logMAR values. So acuity wise, N6 or better was 90% of both groups, N8 or better 100%. In terms of intermediate vision, N8 or better 90% of cases, N12 or better 100% of cases of both the groups. And distance acuity 6.6, 100% cases of trifocal and 90% ERB lenses. And distance corrected, uncorrected, 6.9 or better, 100% in 2 cases. If you see this patient's visual acuity wise, they were almost comparable in 2 categories of these lenses. But what about stereo acuity, which is our main point of assessment for after binocular implantation of these lenses? As I said in the beginning also, stereo acuity will give you a binocular function of patient. So near and stereo acuity, you can see it can be from 20 arc to 60 arc. Anything better than 60 arc is considered to be a good near stereo acuity for these patients. But Percentage-wise, trifocal, we had 50% cases, and 60% ERB had 20R, which is the best possible stereo acuity in near can be with these lenses. But 100% of these, both the groups had stereo acuity more than less than 60 arcs seconds in these near stereo acuity was concerned, so which is a good results. P-value was significant for cases with better near acuity in these cases. But what about distance stereo acuity with trifocal and ERB lens? There you can see trifocal and ERB had almost equal results. More than all 100% cases had more than 200 arc, which is supposed to be a good stereo acuity for distance with random tests in both the categories in these cases. Let's see what was the quality of vision. We had a good acuity in these cases, good stereo acuity also, but quality of vision we have to look into. We looked into a point spread function in these cases with the eye trace. You can see this is a trifocal lens, a beautiful image, and this is the ERB lens here. And this is MTF at 6 months at 5 cycles per degree. We had a better MTF with cases with trifocal lenses. If you see, this is trifocal lenses. The MTF is better than ERB lenses, and they were p-value was significantly better for trifocal lenses at 5 cycles per degree in these cases. Same for a Stultz ratio, which is basically a function for a contrast in these cases, better with trifocal lenses. So both the MTF and Stultz ratio was better with the panoptic lenses in our study. Second area for study was look into higher order aberration by ray tracing aberrometry in trifocal and ERB lenses. We looked for an internal and total eye higher order aberration. So this is ERB lens, and this is the trifocal lens. We found it was significantly less with the trifocal lenses as compared to ERB lenses in our patient at 6 months. Right from the 1 month to 6 months, they were significantly better with the panoptic lenses. And other area which you look at coma and trefoil were comparable, but if you look at spherical aberration and HOA was better with the panoptic lenses. The next important thing to assess was the quality questionnaire for our patients, the quality of vision, where we look for near work, which I think is important, night driving, starburst and halos, glare, trouble seeing, especially during the night time, especially independence in these cases. Panoptics, you can see 100% no difficulty for near work, and 40% had little difficulty in driving. 10% had some time, but they had a starburst. 20% patient complained a little bit of glare sometimes, but 100% cases had a specular independence, which was 80% of the ERB lenses, which was significant statistically. So if you look into this, the ERB lenses, around 80% were satisfied and 20% were completely satisfied in these group of cases, while 90% of our trifocal lenses had a complete satisfaction as far as the after implantation is concerned. So that shows the good acceptance of trifocal lenses in our series of cases. So you heard that entire literature and my experience or comparing our lenses trifocal with ERB in terms of stereo acuity wise and looking at higher order aberration and other contrasts in these patients. So what are the various ways by which we can select the trifocal lenses? The first thing would be visual acuity wise. You saw that all trifocals would give a good distance acuity, which is not a significant problem. But other concerns, intermediate vision, which I think panoptics would be the best lens because it is at 60 centimeters, where you have a better physiological acceptance for the type of work people do nowadays. Near trifocals definitely perform better than ERB lenses. Range of vision wise, all trifocals would give, but panoptics has the best defocus curve between 40 to 80 centimeters. Second area of interest by which we can convince our patient the quality of vision. As you saw in our comparative study, panoptics is excellent, provides excellent visual quality and stereo acuity, because stereo acuity is the one which is going to give you a much more comfort to the patient's work position-wise as such. Then third important thing is the patient satisfaction. I think whatever we do, if patient not satisfied, what's the point of doing that particular surgery, implantation, eyewear? The panoptics had almost 100% patients were satisfied, either completely or they were very satisfied. As one of the video Dr. Abhay showed, patient might recommend to their other group of friends to go with these type of lenses. But this is a scenario, I think with this presentation, more people will be understanding that trifocal lenses are the lenses for a newer generation multifocal for all distances. PanOptix does have an edge over other trifocals, especially giving a good range of near intermediate vision for our patients. So I would say thank you for listening to this talk. We all desire clear vision and clear multifocality for all our patients. Thank you for your kind listening.